Our topic is distal upper extremity surgical management. My name is Jody Gutkin, and I've been a physical therapist for 28 years. I've also been involved in physical therapy education for over 20 years, and I look forward to discussing this topic with you today. What we're going to review during distal upper extremity surgical management are the common surgical procedures that are utilized to manage both orthopedic as well as common neurologic pathologies in the distal upper extremity, specifically the wrist and hand. We'll review those specific anatomy relative to these surgical techniques for nerves, tendons, ligaments, and bones in the forearm, wrist, and hand. They're really doing some amazing procedures. So we will take a look at those and consider our treatment considerations so that you are able to appropriately follow the physician's protocol. The rationale is to give us a better understanding of both the traumatic and non-traumatic pathologies and how they're managed surgically. I'll briefly go over each condition from the perspective that you have enough of a refresh on it to understand the surgical technique that we're discussing. And then from a treatment perspective, I'll give a little caveat as to what seemed to come up in my research most commonly as to considerations when you're following that physician protocol. My goal is to arm you with the information so that you recognize how to progress the patient and what considerations to have in terms of post-surgical management based on what was performed during the actual surgical technique. To accomplish that, we will definitely be looking at some anatomical structures in this region and images from actual surgeries. So depending on where you physically have your screen, if there are young or squeamish eyes that might be looking at your screen, you just might want to have them prepared that some of the images may not be comfortable for them. But for us as clinicians, it will all be relevant information to the topic that we are discussing. In addition to the actual surgical techniques, we're going to look at splinting and post-surgical complications to monitor patients for. All of the information that I'm presenting is based on the current research, and those references are included on many of the slides. And then at the end of the course notes packet, I have all the references listed there. So if you want to go back and read a little bit more on your own, you'll be able to do that. As with any course you attend, when you go back to apply this information in the clinic, you're going to do so in accordance with the federal, state, and professional regulations where you are practicing. You will notice that several of the slides have this gold icon that says "Consider this" in the bottom right-hand corner. That's to let you know that those particular slides have information that will be helpful when you go to complete the course post-test later on today. Let's begin with a brief review of our anatomy. We're all familiar with the distal upper extremity from the elbow. We have our distal radio-ulnar joint and our wrist joint, our radiocarpal joint, going down into our hands to our metacarpals, carpals, and phalanges. As we look at those carpals, they play a very critical role in functioning of the hands. Their alignment into the two rows is critical to allow appropriate gliding for our fine motor as well as gross motor tasks that we need to perform. I always have a nice chuckle with this, going back to my college days, all those mnemonics we all made up to get through. Mine for the hands, looking at the carpal bones, is going counterclockwise, starting at the proximal row on the pinky side. So I am PTs love Sundays, 10 toppings can't hurt. I was clearly hungry. So we have our pisiform, triquetrum, lunate, and scaphoid, making that proximal row of carpals, and then the trapezium, trapezoid, capitate, and hamate, making that distal row of carpals. And it's important to note that the alignment of these structures is what's going to allow us to have appropriate movement of our hand for our tasks. So when we look at recovery following surgery, glide needs to be maintained in those carpal joints. The normal arthrokinematics, when we look at the bony architecture of the hands, it is going to allow for gliding of those bones so that we can perform our different fine motor tasks, such as writing and our pincer grasps. And then they also need to balance the forces of external loads that may be distractive when we are grabbing onto objects and carrying things. So the carpals play an important role in allowing that alignment, and then because many of our muscles attach in that region, they also allow for appropriate length tension relationships to generate appropriate force. So what happens when there is a surgical intervention? Oftentimes, surgery is necessary to correct a pathology or condition that has developed or a trauma that was sustained. And when surgery is performed, any modifications to these anatomical structures, it'll change the geometry of the bones in the area. The physician makes an attempt to try and restore as much as possible, but there may be shifts that occur. And any minor changes in this alignment can lead to a significant change in those muscle tendon paths that changes the biomechanics that may alter the amount of force that can be generated. There's instances where scar tissue can develop, edema can occur within all of the different layers and muscles and other soft tissue structures that can inhibit movement, and we need to consider during healing. So it's important to be aware of all this through the rehab process. When we look at the different types of surgical techniques that can be performed, we have our two main categories of our open procedures and then the more minimally invasive procedures. Minimally invasive, I've seen it evolve over the decades, and the terminology sometimes means different things. When we look at specifically surgical procedures of the wrist and hand, arthroscopic procedures are going to go in with the camera and tool to go into direct visualization inside of the joint, like in the bottom left image here. And then an endoscopic technique, endo meaning inside, means that they're going in not necessarily through a joint, but they're going in with the small tools and cameras. We're seeing more use of percutaneous techniques in the hand, where the physician is utilizing fluoroscopy or ultrasound to give some type of visualization that he's watching on the monitor, while he can go in a less invasive way with smaller tools in order to execute the procedure for the patient. The goal being targeting the structures that need the surgical intervention without disrupting all of those other paths and structures that are critical in the hands. To accomplish this, there are different types of anesthesia that'll be utilized. When a patient needs to undergo an open procedure, we know that they will have that general anesthesia, where they are going to be unconscious during the procedure. There is more use of regional as well as local anesthesia, regional being some type of nerve block, and then local direct into the area. In both of those instances, the patient will be conscious. Maybe they'll have some type of light sedation, but the idea being that the patient is more conscious and possibly able to participate and provide feedback during the intervention. That may sound peculiar, that many patients may be awake during an actual surgical technique of their hands, but there is more of the use of the Walland procedure. And this stands for wide awake local anesthesia, no tourniquet. Normally what happens, there is significant vasculature in the hands. There's a lot of critical anatomy that needs to be taken caution with in terms of nerves and vasculature and structures in the hands. So in order to have a good visual field, open procedures are often done, but there needs to be a more proximal tourniquet so that there is not too much blood in the field. Well, that tourniquet causes pain, so the patient needs to be sedated. The wallet procedure changes that the use of epinephrine serves as a vasoconstrictor. So that can keep somewhat of a clean visual field for the physician during the procedure. Lidocaine is utilized to provide some pain relief, and as a result, a tourniquet does not need to be utilized. So if the patient is able to stay awake, this has significant benefits during the performance of the surgical procedure. If we think about the fact that during the procedure on a hand where a patient has scar tissue or restrictions of a tendon and adhesions, the physician is able to release those and then ask the patient to voluntarily move to see if the goal of the surgery was achieved. It's going to allow for more immediate assessment and revision if necessary. The patient is able to provide that feedback. It also is more cost effective. And being cost effective, that's not something negative to look at, particularly in this respect. If the patient does not need to undergo general anesthesia, that means the procedure can be performed in the clinic. So it's going to be less cost to the patient when they go through their insurance for that procedure. Also, it's going to be a shorter surgical procedure. They don't have to go through the pre-testing. They don't have to have the time to come out of the anesthesia, so that's less time lost from work, less time lost on testing and impact to their life. So it may allow more performance of surgical interventions for patients with this wide awake procedure. As we look at the different types of surgery today, we're going to specifically take a look at procedures performed to address nerve, fascia, tendon, bone and joint, and then lastly, ligaments within the hand. As we go through each of these techniques, we'll look at the specific anatomy and surgical procedure, and then I'll give you a little highlight of something that emerged in my research as important related to that specific procedure to consider during our rehab. First, we have to go back to that nerve anatomy. And when we look at the nerve, way back, first time learning it in school, you think of a nerve. Yeah, it's one strand. Maybe there's a motor and a sensory fiber next to each other, and it gets compressed, and then the compression is relieved. We know that it's actually much more complicated than that. When we look at the different layers of the nerve, particularly when we consider it from a surgical perspective, it's important to see the different layers and bundles that are located there. So at the deepest level, we're going to have our endoneurium. This is going to be the inner part of the nerve fiber, the axon and myelin sheath. And then we're going to have several of these bundles that come together that'll be wrapped around with a perineurium. And we see here those little groups on the side here on the left, also on an actual slice under a microscope. And then we have within those different bundles, we're going to have located our vasculature. And it's important to remember that there is a vascular supply to the nerve itself that's coming in here where we see number 1. In between all of that, we have a connective tissue layer. And all of this together is going to be our nerve. When there's injury to the structure, it can happen several different ways. If there's a laceration to the nerve, this can occur from some type of penetrating trauma, such as a knife wound. There could be a fracture that shifts and severs a particular nerve. Traction injuries, these occur sometimes with motorcycle accidents or during childbirth. There may be traction on the brachial plexus where there's a stress applied longitudinally to that nerve. And then we have our compressive pathologies. Those are going to either be a situation where we have a cyst or lipoma, some physical space-occupying lesion that in the carpal tunnel or Guyon's canal, that's placing pressure on that nerve, or we have where the structures within the tunnel, the tendons and other tissues have become enlarged, making it a smaller place, decreasing that volume, placing compression on that nerve. Depending on the specific nerve injury, we fall into our different classifications. Neuropraxia, that tends to be more mild, where there is a stretch to that nerve. The axon is going to remain intact, and it could also be a compressive pathology. Axontomesis is more involved, where there's more compression along that nerve or a greater stretch that is going to exceed the elastic limits. So not only stretching those nerve fibers, that connective tissue and vascular supply becomes overstretched to that nerve. That can cause damage, and then it goes through the Wallerian degeneration process in order to heal. And then the most severe trauma is where there is a complete transection with disruption of the nerve fibers as well as that connective tissue and vasculature. That's the patient who requires surgery. Well, if we remember back to the first time we're learning about regeneration of nerves, we see these images on the left here, right? It's, the nice fiber and the axon and the myelin sheath, that it just regenerates. Nice straight path, and there we go, healing has occurred. That's not exactly how it happens. And if we look on the right-hand side here, this is a scan. It was a sciatic nerve that was purposely transected in an animal study in order to look at the regeneration process. And when we look at the top image, we can see here, as that nerve is attempting to regenerate, I'm just loosely drawing the lines that show the pathways that those nerve endings, as they were trying to regenerate, actually took. It's not smooth and clean. Many of them, and this is after about 90 days, they were just going off in different directions. So oftentimes surgical intervention is necessary to tell those nerve fibers which way to regenerate in, so that we can ultimately have reconnection to that end organ in order to restore function. So nerve repairs may be required for patients who have lacerations. When the physician looks at connecting that nerve back together, there are a lot of considerations that he has to account for. And one is that there has to be enough length within the nerve to coapt those two ends back together without too much tension, where it may separate back out. And within that nerve, remember we looked at, there's sensory and motor, there's vasculature, and they don't line everything back up and stitch each back together. What's described in the different surgical guides that I read is that the epineurium, that outer layer, will be reconnected, and the way they decide how to line things back up, because we want to make sure motor ends up motor, sensory, is they look at those vascular tracts, and they'll line up the vasculature of those endings. And when they sew this back together, it's described as kissing your mother, not kissing your significant other. And that was the surgical guide's way of saying you're not really tightly binding the ends of this nerve together. You're bringing them close so that they can repair, but you don't want to strangle them because that can compromise the circulation and the repair and not allow regeneration to occur. Sometimes there just isn't enough length to have those ends brought back together for that primary repair. In that case, grafting may be necessary. Autograft is one type that might be utilized where they will take a nerve from a patient's different area in order to move it over, and that provides a scaffolding bridge to let the nerve know where to regenerate to. Allograft is another option. Sometimes they will utilize umbilical cord that has been cleansed of all the cells. They remove all of the matrix because they don't want the patient to have to be on long-term immunosuppressive agents. So they clean it out so they only need short-term and there's no cells left from the donor, and that provides a little scaffolding to allow for regeneration to occur. Another option is to utilize some type of artificial conduit. And when they look at utilizing artificial conduits and the way that they're developed, it has to be biocompatible. The synthetic way that it is developed has to allow for it to be biodegradable once healing has occurred. It has to be neuroconductive, it needs to be flexible in the area. So there are a lot of considerations. And when it looks like, it kind of reminds me of like a little piece of straw or a soft stent. And when they place this in the top image across the defect to bridge the area, it is going to be hollow, but within it, it has a little bit of a fibrin bridge. So it's putting a scaffolding inside there. And within that, they also place a matrix that is going to have a nerve growth hormone to supply some nourishment. And what happens over time is as healing occurs, there's retraction of that fibrin bridge of the conduit that's artificial as the axons are regenerating. The example that we're looking at here surgically is that of a 49-year-old individual who had a knife cut to the forearm where their radial nerve was severed. And what they did here, I'm drawing a black line in the second image. I don't know if you can see, there's a little space there in the nerve. And then in the next image here on the right, we can see the little white conduit that was added. The individual went through the healing process. There was a little bit of wrist drop and sensory changes, but some recovery was achieved for the patient. And then 23 months later, if we look at that same area in the bottom image, we see that it's just the nerve and that conduit is gone. Another option for surgical intervention is a nerve transfer. This might be utilized if there's just too much of a defect into cross with these other options, where there is concern that the amount of time that it would take for the nerve to regenerate, that end organ, particularly the motor end organ, it may become desensitized. After about 18 months, the degeneration that occurs, even if the nerve gets there, may not allow conduction to allow appropriate recruitment of that muscle. And they look at this to see the integrity of that end organ when surgical options are being explored. So if there's that concern, it might be better to utilize a nerve transfer. And when a nerve transfer is considered, it's going to have to recognize, well, where is that donor nerve coming from? Because it's an intact nerve in that same patient. It has to be close by so that there's not too much tension on it. It needs to be able to reach. Has to be non-critical. It can't be sacrificing another important sensory or motor area. And it is a consideration in order to maybe sacrifice one area to make gains in another. For example, we know that we need sensation in the palm of our hands for functional activities. Maybe could they give up a sensory nerve from the dorsum of the hands to move it over? And same thing with our motor. They're looking at redundancies in our muscles. We know there are a lot of synergists, so maybe could a motor branch be pulled from one muscle to give it to another one that has been damaged. There are specific patterns that they look at, and it's been kind of predetermined what nerves or options to utilize for other areas. Some of those examples of donor sites might be where if we are looking at grip and pinch being very important, if that ulnar nerve is lost to those hand intrinsic muscles, they might pull from an anterior interosseous branch of the median nerve. If we're looking at sensation, that is going to be lost from that median nerve where the sensory is going to be diminished for those critical grasping and functional tasks. Well, maybe they will take the ulnar digital branch that goes to this web space and move that over. It's important that we recognize on this nerve transfer, here's an example of it here on the top image, that we know what is the donor site to the recipient site. It might mean that in our education for the patient that we recognize that they may not have full sensory return in the donor area, and we need to educate them for safety. In terms of motor, we're going to have to look at strengthening up the other synergists for that action where the donor site was also, in addition to rehabbing the recipient portion. Some complications that may occur with the different nerves. One is a neuroma. This is where we have that hyperplasia, that overgrowth of the nerve. The patient is going to start complaining from that scarring of the nerve of different sensory changes, numbness, tingling, itching, irritation. It'll just depend on their presentation, but they're going to have pain as their primary report. When the physician goes in order to look at that nerve to address it, when they examine the nerve here, I'll circle it in black, we can see the neuroma. It looks like excessive large overgrowth of the tissue. When that's resected out, the patient may then need one of these other procedures to try and restore the nerve functioning to the end organ or to the sensory area. When we look at the patients following nerve repair, grafting, and different nerve transfer techniques, oftentimes they're going to come out with some type of immobilization. This is necessary so there's not too much tension on that graft site or that transfer site to disrupt it. And we also don't want strangulation of it because healing needs to occur. Usually if it's a repair technique, they're immobilized for approximately 3 weeks while healing is occurring. Transfers and grafts, you might see in the protocols that it's less time that the patient's immobilized for, maybe even only 10 days. That's because when they do a transfer or a graft, they've accounted for the length. They've made sure that there's not too much tension on that nerve, and then that will allow for earlier mobility to occur. The way that we're aware that sensation is returning for the patient is that they're initially going to report hyperesthesias. This is a positive sign when the patient starts to report that they're having tingling or itching in the area. If you're working in pediatrics, it's important to recognize the patient education directed towards the family about this. It's documented that in pediatrics, the child or the baby will often start to gnaw on their fingers because they have that abnormal sensation, and they have no way to verbalize what they're experiencing. So it's important to recognize for the family that they know, yes, it's positive sensations coming back, even though it's traumatic that your child is gnawing and maybe creating sores in their fingers that now also need to be addressed. As recovery is occurring, particularly related to sensation, we need a lot of patient education to avoid other injuries, particularly related to hot and cold. And once there is some volitional movement in terms of motor response, we can start using our alternating current electrical stimulation. As we look at return of motor function, we need to re-educate the patient now, if they had a nerve transfer, on how to recruit. Biofeedback is often beneficial to give visual with the lights and auditory feedback we can set the sensitivity so that even the slightest recruitment, the patient can get that positive feedback that it's occurring. Mirror therapy may also be beneficial where they're replicating the motion bilaterally to give some visual feedback. So they're seeing in the mirror their uninvolved arm creating the motion to help with that cortical mapping. And then in terms of actually teaching the patient how to recruit that new muscle innervation, I read many different protocols, and I'll be honest, they were all slightly different. What seemed to emerge as a commonality is the cortical mapping that has to occur needs to address the patient bilaterally, and it needs to start with recruiting the donor site, like consciously thinking about recruiting the donor, and then progressing to weaning off that and thinking about recruiting the recipient muscle. So it's a progression. As the patient goes through the rehab process, early in phase 1, we're doing high frequency, low load type of recruitment, putty, grip, isometrics, and then later on we're going to progress more to the active and the resisted type of movements. Considering our different compressive neuropathies, we have our nerves that pass through many different bony tunnels in this distal upper extremity, and that's what we first think of when we think of compressive neuropathy. I wanted to highlight this particular case. It has us thinking about compressive neuropathy in a little bit different way in terms of our patient education. If you are part of a team in an ambulatory care center, and part of your education you might want to consider is related to the venous congestion that can occur post-surgically, and we're seeing these patients go home sooner, so we might be seeing them earlier in home care as well as outpatient, even if it's not an upper extremity procedure that they had done. This example, when we look at the image on the left, all of us can probably quickly assess what's happening here. This patient had ambulatory surgery, uneventful, for an abdominal procedure. Child was 12 years old, went home, and then later that evening presented to the ER with complete motor and sensory loss to the entire distal upper extremity. What happens is a compressive neuropathy because they presumed how it developed is after the ambulatory surgery, patient put their watch back on. We can clearly see the impression of it. Went home. They were still coming out of the anesthesia, so they fell into a deep sleep. The positioning of the extremity, however it was positioned, did not allow for the venous return, and it led to that compressive neuropathy. I just highlight this as a way of thinking comprehensively in our patient education, because we may tell patients, don't put anything around, that can cause restriction around your limb. Keep your arm elevated. But do they really know what we mean? We may need to give specific examples, because a lot of people will just go grab, particularly for that smartwatch, and throw it back on without even thinking about it. Other compressive neuropathies that we're more likely to see may involve surgery when conservative management has not been successful in order to alleviate the compression on the nerve. One example might be someone who has a ganglion cyst. These are common in the hand. On the bottom image here, we see them in the palmar surface. Ganglion cysts seem to come and go. What we do know now at the top, we're looking at an ultrasound image, is that it's a communication. They say it's like a little stalk that comes out either of a damaged synovial membrane or a damaged tendon sheath, and then it creates a little pouch. I see ice cream on a cone, but the research describes it as a balloon on a stalk. Either way, what happens from this is it can sometimes be drained out to relieve pressure, but it can cause motor and sensory changes if it's in an area where it's compressing on that nerve of an enclosed space, and surgery may be necessary in order to remove it. When we have patients that present with these cysts that have motor and sensory changes from the compressive neuropathy, the procedure might need to be an open procedure. And here's an example as to why. If it is drained and it continues to return and compress that nerve, we know that long-term nerve compression can lead to permanent motor loss and sensory damage if the neuroconduction is not restored. This particular patient in the top image here, I'm going to outline the cyst. We can see the cyst here inside of that black circle. We also see our tendons as well as our nerves. Doesn't look so big, right? We're in the carpal tunnel region here. Well, when they actually moved those tendons out of the way, look at how large this cyst is. So you can imagine the compression that this is placing. Our conservative management is not going to address this. So what they need to do is they need to remove the cyst and they need to remove the sac so it doesn't keep refilling on the patient. Carpal tunnel syndrome can arise for many different reasons in our patients. It's that entrapment of the median nerve beneath that flexor retinaculum within the hand. When we have this compression of the median nerve as it passes through this retinaculum, we're going to have sensory changes and potentially sensory loss along that index, middle, and thumb region of the hand on the palmar surface. And then we're going to start to see motor loss as it progresses, affecting particularly grip, may wake the patient up at night. Conservative management, if it is not successful, then the patient may need surgical intervention. Looking at our carpal tunnel anatomy, we have our flexor retinaculum that comes over the top and forms the roof of this carpal tunnel. And then we have all of the tendons of our finger flexors, that median nerve, as well as the vascular supply that goes through there. We know that each tendon has its own sheath to allow it to glide, but it's more complex anatomy than that. We also have our nerve and our vasculature in there. So as all these structures are intermingled, within all of them, we have a subsynovial connective tissue that allows the whole area to also glide freely to help resist the different shear stresses that occur as we're performing our different movements. If the patient has a pathology maybe related to overuse, where there's too much bulk in that area and it's not healing and conservative management has not been successful, they may need a carpal tunnel release. This can be done in several different ways. One option is for the physician to go in and do a complete open procedure, like we see on the right-hand side here. The first to do the carpal tunnel surgery was Dr. Phelan, and his name may sound familiar, right? We know our Phelan's test to test for the compression. He actually did this back in the 1950s for the first time. The idea with the open procedure is they are trying to release that flexor retinaculum in order to relieve some of the pressure on that nerve because it's an enclosed tunnel that's located there. They'll go in about at the wrist crease in between the thenar and the hypothenar eminence. The mini open repair is another option where you'll see the incision in a similar region, except on the left-hand side here, it's a much shorter incision that is utilized in order to allow access. I tried to find some research to see which procedure has better outcomes. For the most part, I didn't find anything specific that one was better over the other. It might be that the mini open repair, that earlier on the patient has greater relief and that they're able to return to their activities sooner because it's a smaller incision. But ultimately, over time, it seems like the results are equivalent for the patients. Endoscopic carpal tunnel release is a procedure that is utilized to go with an even smaller incision in the area. This is where they can just go in with the camera and the tools. It is a very, very tiny, we see here, incision that is utilized. With this procedure, we're going to consider that the physician is not opening up all of the other superficial structures, so there's less risk of damage to those and disrupting all of the length tension relationships, less opportunities for scarring in those tissues. With the endoscopic repair, they did cite in the research that if your patient has undergone this specific type of release, that the ulnar artery may be at a greater risk of being disrupted. So if you're monitoring them post-operatively, when you look at your vascular return and your different provocative tests to look at circulation into the area, you might want to pay a little bit more close attention to vascular supply from that ulnar artery if the patient has the endoscopic release specifically. Because that wasn't enough, the ultra minimally invasive carpal tunnel release procedure has been developed. And this, to me, anatomically, it makes the most sense. When we think about the carpal tunnel, that flexor retinaculum has different layers to it. And if it's deep into the tunnel here where there is not enough space, does it make sense to zigzag cut and open everything up? Well, this procedure says, well, why don't we go in here to that undersurface of that retinaculum and release it here? The way that the procedure is performed, it's going to use ultrasound guiding. So on the right-hand side here, we're going to, if we look at the instrumentation below here, there's ultrasound guiding on the outside here. And the physician is putting in, it looks like a thin metal hook that has like a little hook on the end. And on the left-hand image here, what you're going to see to orient you, the left top, this is going to be our median nerve on the right-hand side. Here is our artery. And then across the top here is our retinaculum and then our carpal bones here. Looks like he's smiling. So what they're going to do is go in with the needle on the right-hand side. So this hook is the white line above what I'm drawing. And then if you look at where I'm putting these little dots adjacent to that, so they slide the hook in sideways, and then the physician will flip it up and apply an overpressure onto the hand with the ultrasound that he's looking at with the transducer, and they scrape the inner portion of that retinaculum. And that's what we're seeing here on the bottom left image. So just above here, we can see the hook going up into that retinaculum. And then in the far right here, we can see the rough edges of where that retinaculum has been released. So it's just going in, and as this percutaneous procedure is just releasing specifically where those deep adhesions may be located. And it does not disrupt all of the architecture in that area. And that's a thought for our patients who have the more open procedures. Some physicians may incorporate into that surgical technique a flexor retinaculum reconstruction. Oftentimes they'll do like a little zigzag inside in the retinaculum to allow it to lengthen. Others may actually look at putting like a little silicone sleeve over it because we don't want all those tendons to bowstring or fall out as the patient performs their movement. We still need that length tension relationship maintained while debulking where that nerve compression is occurring. The concern over time, why some physicians may choose to utilize the reconstruction, is that the carpal distance They may start to migrate if they don't have the retinaculum to hold it in place. That may lead to that bowstringing of the tendons, alter grip and pinch for the patient. When I looked at different studies to see if this was really beneficial or not compared to other procedures, there was a 2019 review. They looked at several different studies, about 600 patients. They said in the short term that the grip was different in the patients that had the retinaculum reconstruction versus those that didn't. But in the long term, once healing had actually occurred, that they had very similar outcomes in terms of their grip and pinch strength. So one procedure wasn't necessarily better than the other. However, it would be interesting for you to know which of these types of releases your patient had, because we can't just say they had a release. Now we know there are so many different types and procedures, and that might explain why some patients are progressing differently than others, and why we may need to modify our protocols slightly. And you may see some patients progressing faster than others. So you might want to know from the physician exactly which procedures are being utilized for the release. When we look at our patients following their carpal tunnel release procedure, it's kind of like lining up all your patients that had a total knee replacement, where you see the different, slightly different incisions. What you may notice on your patients with carpal tunnel release is the color of their sutures may look different. And there's actually a reason for that. I kind of use similar colors on the chart here. There are two main types of sutures. There's absorbable and non-absorbable sutures. The non-absorbable sutures are the ones that you are going to see external on the patient, and those tend to have those multiple knots on it, and it tends to be like a dark green in color. The reason they put so many knots in and why it's so dark green or even black is it's so fine and has such a high tensile strength, meaning it wants to unwind back out. The coloring is so that the physician can see it, and then the multiple knots are so that it holds its space, because it has such a high memory to it that they need to make so many knots. Now, the absorbable sutures are a little bit different. The coloring on the suture actually plays a role, that the chromic controls the absorption of the suture. So the first type that is usually utilized below the skin, if you have the opportunity to read the op reports, you might hear it referred to as monocryl, and they tend to be purple in color. These are more pliable synthetic type of material. And when it's utilized, when we look at the tensile strength and the role of the suture, it's to hold the tissues together while they're healing. And particularly this type of suture is going to have its initial good tensile strength to hold the tissues together for about the first 7 days. And by that point, by day 7, it's down to around 60 or 70% of its original tensile strength. As healing of the body's own tissues continues to occur, by day 14, it's at about 30 to 40%. Then by day 28, it is going to not have any tensile strength left, but there may still be some of the suture in there. And then it takes ultimately 90 to maybe 120 days for it to completely dissolve. The chromic gut sutures, those are going to be from either beef or sheep intestine, where they thin out and spin out the collagen. As again, a very high tensile strength. It's more of a natural tissue. They polish it, and this tends to resist the deterioration, fraying, has good strength to hold the tissues together for about the first 14 days, so a little bit longer. And then by day 21, it still has a little bit of its strength left. I tried to find some research where, which one's better, why use one over the other. And the best that I could find was a 2018 Cochrane review, where they pulled 5 different trials, 250 patients. And it was research from several different countries, UK, Ireland, Denmark. I was just grasping to try and find something concrete to tell you. What they looked at were patients 1 week and 12 weeks post-op of their carpal tunnel release. And they looked at pain, inflammation, and healing based on the type of sutures that were utilized. And they really found that there was no difference in the ultimate outcomes for the patient. The only difference that came up was that the absorbable sutures are a little bit of a cost savings. Again, in a positive way, it didn't require the patient to go back to the doctor for another visit, have another copay if healing was occurring fine. Unfortunately, what they did find is that patients with absorbable sutures tended to be slightly more prone to scar tissue developing, and that is something for us to be aware of, to be diligent in educating those patients in particular in their scar work, and for us to continually assess that so that doesn't compromise their ultimate functional recovery. When patients have carpal tunnel release surgery and we see them coming out, they're going to have some type of bulky dressing on like this for about 2 to 3 days. And the American Academy of Orthopedic Surgeons does not recommend splinting, that 2-week long-term splinting as they're healing is not recommended any longer, even though they're not really finding much of a difference. They're not finding any specific benefit to those patients, and there's actually a concern that by not having them move, that it could be more detrimental to their healing. It may increase adhesions and stiffness for the patient. The use of splinting at night may be an option, or with different functional tasks as they're returning to function. But generally speaking, you're not going to be seeing your patients with those 2-week-long splinting where movement is restricted following their release. Complications we're going to monitor our patients for, particularly when they have more of an open procedure. There could be injury to the palmar cutaneous branch of the median nerve. This is going to give sensation particularly to the thenar eminence. So as we're looking at our patients who have median nerve compromise, if they have specific loss of sensation in that thenar eminence, it could mean that that nerve was slightly damaged. Maybe it's transient from the surgery, but be specific in your sensory assessments. And then also look at your motor assessments to those thenar muscles to make sure that they're recovering appropriately. We're going to monitor all our patients for adhesions, hematoma, infection, and then specifically with carpal tunnel release, we're going to look at complex regional pain syndrome as well as pillar pain. Postoperative pain is something we're going to assess on all of our patients, and I borrowed an acronym from Brigham and Williams Hospital, PAINed. So we're going to look at the place, amount, intensifiers, what makes it better, nullifiers, what makes the pain worse, the effect of the pain on their function, and then the patient descriptors of the pain. We all know to pull that information. When we're looking at the post-surgical patient for the carpal tunnel release, we need to discern is what they're experiencing incisional pain, which is located at that incision site. We can correlate it to the phases of healing. It's slowly resolving in the weeks to days for the patient, and we're correlating it with maybe some tenderness at that incision site. Pillar pain is something specific to individuals who have a carpal tunnel release. Usually this will start to emerge about 1 to 3 months post-operatively when they're starting to return to more function with their hand and doing more weight-bearing activities, pushing the stand, pushing a door open, a drawer. What pillar pain is described as, it's more of a deep-seated ache that the patient's experiencing, and it tends to be located if you palpate those pillars. So the pisiform, the hamate, and then our scaphoid and our trapezium. That is where that transverse carpal ligament is attaching. And if they had an open repair, what the current theory is that as that release happens, so the physician does the release to relieve the pressure on the nerve, well, some of these fibers that were released start to retract back to their bony origins. And then as the patient is using the hand more, there's inflammation that occurs at those sites. And that's what creates the pain and edema for the patient. And then also when they start to use the hand more, the muscle pulls of those thenar and hypothenar muscles on those similar locations leads to that deep aching pain that the patient may have. Depending on the research, they say somewhere between 6 and 36% of the patients experience this. It reminds us to be very specific when we're letting the patient explain what, when, and how they have their pain and the descriptors for it. If it is specifically pillar pain, you would be able to palpate it also, which might exacerbate it. Rest, edema management, scar massage might be indicated, and the research says typically with those interventions it will relieve, combined with activity reduction, let it heal a little, and then return to higher level function. Complex regional pain syndrome. I remember back in the late 80s and early 90s when it was becoming more prevalent, at least in the part of the country where I was practicing at the time. We've just learned so much about this condition now. And with our patients who have hand surgeries, we're looking at instances where that microvasculature in the hand may be impacted, and post-surgically, they are likely to be presenting with more of a class 2 causalgia because there's a definitive nerve injury versus a class 1 or a type 1 reflex sympathetic dystrophy where there's not nerve injury. The key is to catch this early. If they complain of allodynia, which is pain disproportionate to the stimulus that they're experiencing, burning, edema, looking for those trophic changes, change in hair growth, the skin looking different from the lack of nourishment in the area, it may look shiny. And then the temperature in the area, alteration in the amount of sweating in that limb. So we would want to recognize that early to begin intervention. Carpal tunnel rehab, looking for some trends in the research that I looked at. We know now we need to recognize what kind of release the patient had. Generally speaking, early about day 2, the patient focus is on edema control, protecting that joint. We do want to store the regliding of the tendons. When you look at initiating active wrist motion, we're going to be cautious of composite motions. We want to make sure that initially the digits are going to be relaxed when we're performing our wrist motions, that we don't want to combine motions that may stress that repair or create additional stress in that area. We're going to add in our nerve gliding around week 3, scar desensitization, and progress with our strengthening. Elevating at night early on for that edema control is important because we don't want extra bulk in that space that was just released. Looking at the research, this was a little disconcerting, I will be honest, but you know, it took it like a seasoned therapist, and I'm just putting it out there. So I looked at studies at the benefits of rehab following carpal tunnel release surgery, and there was a large 2016 Cochrane review, the American Academy of Orthopedic Surgeons in 2015. When we look at supervised therapy and specific exercise and interventions we perform, there's low quality evidence of a benefit and moderate evidence that there's no benefit of rehab. That it did seem that patients did get better even without therapy after their surgical intervention. So be mindful if you are seeing a patient pre-op, if you're not going to see them post-op, if there was anything important you think they needed to know from a therapy perspective, you might need to add that in. And then maybe know the philosophy of the physicians that you're working with. There was a caveat in the research that there was inconsistent descriptions of what was included in exercise and supervised therapy, as well as the dosage and education. So maybe that accounted for why they couldn't say it was definitively helpful. Overall, looking at outcomes from carpal tunnel release, we have our classic open procedure with that large incision, progressing all the way to that ultra minimally invasive, that is just a percutaneous technique. The American Academy of Orthopedic Surgeons says that there is no significant difference in the ultimate satisfaction for patients in terms of return to work, grip strength. Possibly there's less pain with more of the endoscopic and minimally invasive procedures, particularly early on, but it seems that patients get to the same place. It just depends how quickly they are getting there. Overall, the research seems to support that about 90% of the patients are very satisfied with their results from carpal tunnel surgery. We know that initially a big complaint for patients is the sensory changes and the pain and discomfort that they're experiencing. And the majority of patients are experiencing a decrease in that nocturnal awakening at night. That seems to be relieved for everyone, but not everyone has complete resolution of their sensory symptoms. That there's usually some relief of the daytime sensory changes, but not complete resolution in all patients. And there was a study that tried to hone in more on this based on the age of the patient. And the American Association of Hand Surgeons, in a 2018 review of over 1,000 patients, they looked at them preoperatively and 6 months postoperatively, and they found that the older the patient was, the less likely they were going to achieve complete resolution of their sensory deficits from the carpal tunnel compression. If someone's under 40, about 71% achieved full recovery. Under 80 years old, 60% achieved full recovery. And if they were over 80, only about 43% had full sensory return. Another area for us to highlight, particularly related to safety and patient education with persistent sensory loss potentially occurring. Return to function seems to be a little more consistent. Most patients have a significant improvement within a week of their function. By week 2, they're performing their ADLs, and by week 6, they're going to that normal return to work, and that's where we're starting to monitor them, or at least have them aware of that pillar pain to see if they need to slow the progression with that. A couple of areas to highlight. When we tell the patient that they can get back to their functional activities, particularly early on in those first couple of weeks when they're still recovering, we might think automatically that we know vibration can be detrimental to the microvascular circulation in the hands and potentially compromise healing. Our patients may not think, well, I shouldn't be using an electric toothbrush or an electric razor. Or it's okay if, yes, I'm wearing a little bit of a daytime splint when I'm doing my activity and I work as a nail tech and I'm using that vibration. So we do need to think of that being specific of our patients when we look at what specific work and self-care activities they are returning to. Even with lifting, if they're going to lift something and we tell them to lift something light, well, what does light mean? Maybe we need to educate them. You know what? You should slide something to you and then try to pick it up, not have that long lever arm. Just more opportunities for us to be specific in our patient education. Moving on to our ulnar nerve compression syndrome. This can occur at a couple of different locations. One is Guyon's Canal, looking here in the area between the pisiform and the hamate, circling on here. And then if a patient has compression of the ulnar nerve in that area, we are going to see weakness in the hypothenar muscle, the hand intrinsics, the gripping type activities. And then we can also have compression of that ulnar nerve, we know medially here, behind that epicondyle for the patient. Depending on the mechanism of injury, whether it's a space-occupying lesion, a cyst, or a lipoma that needs to be removed, or if the patient had some type of fracture that has shifted the mechanics in the area, they might need different surgical interventions if conservative management is not successful. This is an example of a patient with a cubital tunnel cyst. We know in this area where the ulnar nerve, I'll go black here, is coming down. This particular patient has a cyst in that area that's compressing on it that needs to be removed. On the top right image, if someone has a fracture of that supracondylar area of the humerus, it can shift and change the mechanics of the tunnel, compressing on that nerve. And then if they're placing pins in order to stabilize a fracture, the pin location could compress on the nerve itself. When we're monitoring patients following these distal humerus pathologies, we also need to be mindful of monitoring them for the compression or potential irritation of that ulnar nerve. couple of different procedures that can be done to address compression that might be occurring of the ulnar nerve. On the left-hand image here at the bottom, we see that nerve is pulled out of its space. Pick a different color here, sorry. Is pulled out on the bottom left here, just above that black line that I drew here. They can just go in and decompress, debulk that area. Maybe there are osteophytes on the bone from arthritis that is compressing it. Anterior transposition is an option where they will take this ulnar nerve on the bottom right image here from where I drew the black line, and they will move it up over the muscle belly, and then they take like a little fascial flap to create a sling to help hold it in place. So they have physically relocated it. An epicondylectomy, where they actually resect out part of that medial epicondyle. The concern is that it could potentially destabilize the entire elbow for the patient. So if a patient has a decompression, you do want to know which specific procedure they underwent, because your anatomy has changed, your scar tissue may be in different areas. Looking at the motor component, depending on the length of time that there has been compression of the nerve, the patient may experience permanent motor loss of that distal musculature. When we look at the grip and the lateral prehension that's necessary, the patient may lose that first dorsal interossei that creates index finger abduction. So the physician is going to check to see if they have that motor strength, if integrity, I should say, of ability to accept the electrical signal down to that motor end unit. If not, what they might perform is a tendon transfer. The way that they're going to accomplish this is they're thinking of restoring that lateral prehension that is so important for function for the patient. They're going to take the extensor pollicis brevis here from its insertion on the proximal phalanx. They resect it off and they feed it and pull it back out here through the anatomical snuff box. Then they take the tendon under the skin, feed it back down to that location where the first dorsal interossei would be located, and now the extensor pollicis brevis has a similar line of pull so that it can contribute to that lateral prehension. We would need to know which specific tendon was transferred. They can also do this with the abductor pollicis longus in order to try and restore that pincer grasp. And then this patient would likely need some motor re-education in addition to our other rehab techniques. I think it's pretty amazing how they can do this, and they figure out all the lines of pull to restore that function. Someone who has a Guyon's canal cyst, so we're coming back down now into that ulnar aspect of the hand by the pisiform and the hamate. This reminds us we need to know what we're palpating, and when we are looking at our patients and their function, that maybe they are having difficulty with their gait because they're having trouble holding an assisted device, or they're having challenges with dressing if they have a lower extremity involvement because their grip is off in their upper extremity and something's creating pain. We're diligent in looking at where exactly is the problem that we need to address. And this was an interesting case that I read that I think highlights this. It's a patient who retired. They had been a fisherman for 40 years, and now they're 77 years old. Intermittently, they would kind of get this fleshy lump on the palm of their hand, but it became very uncomfortable. The individual started having significant sensory changes, and when they went in, this was a huge lipoma that the individual had on their hands, and now it was becoming symptomatic, and they needed to remove it to relieve the compression in that Guyon's canal. So when you're palpating your patients, and if something doesn't feel right with the anatomy, this is more extreme because we can visibly see it. When in doubt, communicate back to that physician, and if a patient comes to us where they've had a release of a particular canal, it might just be interesting to know if it was a cyst that was causing the obstruction. Procedures to decompress the Guyon's canal, patients are going to present very differently in terms of their motor and sensory impairments. And what they found in this particular canal is that the anatomy is very varied. There's a motor and sensory branch that comes off of that ulnar nerve as it passes through. They did studies where they looked at 50 different cadaver sections, and they found so many different pathways. And I'll just highlight a few in black here. Looking at the different branching of the nerve as it passes just through this thin canal, I'm just drawing lines overlaying the different branches of the nerve, and it's so different, the anatomy in the area. And the anastomoses and pathways that it takes. So know that your patients are going to present very differently if they have Guyon's canal compression, and then even post-operatively, their recovery may be different. Maybe the order you need to do your exercises in as motor return is restored, where the weakness is located, where the specific sensory loss is, may be slightly different. Every patient may not look the same, so we need to be specific in our rehab for those patients. And they even found that in about 57% of the patients, there was an interesting anastomoses with the median nerve. So some patients were even presenting with some median nerve involvement. Moving on to our fascia. In the distal arm, compartment syndrome involves altered hemodynamics in the fascial compartments in the distal upper extremity. We have these different areas where we have the bones in the middle and then our compartments where our muscles are passing. In addition, we have our nerves passing through and our vasculature. Individuals can either have acute compartment syndrome if they have a closed fracture in the area. This top image is an individual who had a closed fracture of the distal radius, 68 years old, and then developed compartment syndrome. The bottom image is of an individual who had a cat bite 6 days ago and developed compartment syndrome where there's altered hemodynamics. The venous flow can't get out, the arterial flow can't get in. It is considered a medical emergency, because as that swelling continues to increase and there is not vascular supply in the area, there can be significant damage and necrosis of the muscle tissue also. Patients are going to present with the hallmark sign of pain disproportionate to the injury. They will have paresthesias, altered sensation. That limb will actually be colder because the lack of warm arterial blood coming in. Some patients can even present with compartment syndrome because of long-term chronic pathology where they have overuse of the muscles in the forearm that created a lot of swelling. way, however a patient develops compartment syndrome, it does need to immediately be addressed with usually a decompressive fasciotomy. This is the same individual who had the cat bite. So they went in the top right image and they made incisions into the hand compartments, and then they also did so on the palmar side to allow release and draining. The concern is if the pressure continues to build, that there can be damage and to the tissues, significant ischemia, and risk of amputation. This particular patient had good recovery. We see her images in the right bottom, middle right, I guess here. She had pretty good return of function after about 2 months post-op. In some patients, they may need to leave that area draining for a while, particularly if it's also infected. And what they might use, like on the bottom right image here, is I'll put adjacent here. They'll use like a silicone tie that they might use to mark different vessels during surgery, and then kind of lace it so that the area can stay open, the skin won't retract, in hopes that they will have enough skin to cover the area. If not, that patient, like on the left here, may need a skin graft in order to cover the tissue. We might see these patients at various different points during their recovery, maybe early on for wound care or later on for return of strength and function, and then scar management also. Volkmann's contracture is a concern that can develop as there's liquefaction of the muscles in that compartment. As the compression occurs and there's increase in the fluid in the area because there's no venous return out, as the muscle is breaking down from the ischemia because of the lack of arterial supply coming in, there are different degenerative enzymes that are released. As those enzymes are released and they can't be moved out either, they continue to build up. That just kind of perpetuates that cycle of necrosis and liquefaction of the muscle components, and that leads to the Volkmann's contracture. It's graded in different ways using a classification system based on how many of the tendons are involved. And as in the image here, the patient will end up with different contractures that occur of their fingers. The hope is to catch them before this occurs. If a patient has a Volkmann's contracture where they no longer have a tendon that can insert to create movement, or if they have another pathology, I had seen patients where they were butchers and maybe they cut their hand and severed some tendons, or someone who puts their hand through a window. There are many different types of accidents and injuries that can happen where someone does not have an intact tendon, and a tendon transfer is necessary in order to restore function for them. The physician needs to determine, well, where does that tendon come from? The first thought is that it has to be expendable, meaning it needs to come from a donor site where the patient has other muscles that can continue to perform that function, or it's a less significant function that could be sacrificed for something more significant. Where we can play a role is that we need, if we're seeing them preoperatively, that it needs to be pliable soft tissue. They need to be able to resect out that tendon, have enough length and elasticity on it to move to the donor site. We also have to have good 5 out of 5 strength of the donor site, because immediately it's going to lose about 1 grade strength from the tendon transfer. And then the physician, if you're reading the op report, you might see reference to the Smith's rule. And this is how they decide where they can take one tendon from to move to another location. That as we look at the excursion that our different tendons need from all the different joints, they need to have a different amount of length to them to be able to perform their function and maintain their length-tension relationship. And this is called Smith's rule. That the extrinsic finger flexors, the ones that originate outside of the hands, they need to have about 7 centimeters of excursion. Then 5 centimeters of excursion is required of our extensor pollicis longus, our extensor digitorum. And then our wrist flexors and extensors need about 3 centimeters of excursion. And this comes into play to ensure that contracture doesn't develop and that there's appropriate tension in the muscle to allow for function. They've also looked at different patterns related to the muscles. Each muscle they've determined has a relative strength to it, and that is related to its cross-sectional area, its line of pull. And they need to make sure they don't over underpower, particularly in the hands, a particular motion. Here's one example. The brachioradialis here, which we know the brachioradialis is an elbow flexor. It doesn't work at the wrist, but its insertion here in the radius and the tendon running in that area gives the physician an opportunity to utilize that for tendon transfer into the hand. If they were to take that brachioradialis and transfer it here for my extensor pollicis, well, I don't need really strong finger extension. If you overpower my finger extension, even the resting tension in it, I may not have enough strength of my remaining muscles to perform a good functional strong grasp. It makes more sense through the mapping they've determined to use that brachioradialis, transfer it over here, which it's close in proximity to that flexor pollicis, and now you're using a good strong muscle that's transferred to create good strong grip. So we want to know what muscles are transferred and moved and know that they've done a lot of research to try and figure out what can go where. As we look at flexor tendon injuries, specifically in the hand, it's a complex mechanism. I'm oversimplifying it. If we have any hand therapists listening, know that I'm oversimplifying it to what we need for the context we're talking about today. When we look at the flexor tendon mechanism, we have our flexor digitorum profundus and superficialis that come from the forearm down to allow finger function for grasp. The flexor digitorum profundus is inserting on the distal, inserting to allow movement of the distal interphalangeal joint for that finger flexion. And it's also the deep muscle located here on the forearm. In order for that tendon to get down into the finger, it has to cross through the tendon of the flexor digitorum superficialis. And that's what we're looking at here. So we have, I'll draw in red, the flexor digitorum profundus tendon coming down. And then we have the tendon, I'll go in blue, of our flexor digitorum superficialis. And what that tendon does, because it creates movement on the proximal interphalangeal joint, is it kind of splits. So the tendon's coming down and it splits, and then the tendon of the flexor digitorum profundus sneaks through it. So we can see that it's a complex mechanism in there, lots of places where adhesions can occur and different injuries. This is called Camper's chiasm, where they actually cross, and that's really important to allow for appropriate functioning. Another consideration the physician has is how are all these tendons staying in place? That the anatomy is built so they don't bowstring or fall away from the finger. One component that helps with that, they're called our annular rings. So think of when you have a fishing line, you don't want the line to fall away from the string of the line to fall away from the pole itself. So you have those kind of like eye rings on it, so that as you're casting out in the top here, and this is your pole, it doesn't fall away. It has like these little rings on the fishing pole. Same thing happens on our fingers. We have on the bottom left image these annular rings to help hold it in place. And then we additionally have cruciates, like in our knee, crisscrossing, so those don't slide off. I explain this because when they're doing surgery in the hand, there is so much to think about when there's an injury to these different flexor tendons. Because the anatomy changes as you go down into the hand, this mechanism we're talking about is more in the fingers. There are different zones of the hand when they're looking at where the injury occurs. A zone 1 flexor tendon injury is going to occur near the tip. This is going to be when someone grabs, like a jersey injury, someone grabs on and they're trying to flex the finger, but there's a force moving it out into extension and they get a rupture. Zone 2 injuries are in this next box where we really just talked about in the finger itself. And this was historically known as no man's land, where they really didn't go in and do surgery there because of the complex anatomy. But there's so many advances now that they are able to be more successful in this area with different surgical techniques to restore function. Zone 3 is going to be in the palm of our hand. 4 is going to be near the carpal tunnel. And then a zone 5 injury is going to be coming more into that distal forearm. We'll see more vascular involvement and a lot more nerve involvement. And it's important for us to know where the zone of injury is that we're treating. As the physician performs the surgical technique and looks ahead to actual healing of the structures, there are several components that are beneficial to contribute to this healing process. The tenocytes themselves are going to stimulate the healing process, and then we have synovial fluid and inflammatory cells that come in to allow healing. The way that communication of the circulation gets to those tendons is through little vanicula. And what we're looking at here is that Camper's chiasm. So I'll draw in red here. We see that flexor digitorum profundus coming down. And then in green, I'm drawing in the little vanicula that come from the tendon. So they kind of come off and they allow circulation from the digital artery into that tendon for healing, and they also kind of serve as a little catch. So when someone has a tendon rupture or tear, it's another check to kind of stop that from recoiling also all the way back down. When the physician looks at timing repairs to the flexor tendons, it's going to relate to the zone of injury. The best hope is to have that repair occur within the first 24 hours, so it can be a direct primary repair. As they're waiting up to 14 days, maybe there needs to be other injuries addressed, or there's an infection that's occurring. The tendon could be shortening down, which may not allow for a direct repair. And then after 14 days, that patient may need a more complex or involved procedure with some grafting in order to restore function. Primary tendon repair is where they're able to anastomose the two ends of that tendon. In the top right image here, we're looking at an individual who had that jersey injury. They were playing rugby and had the injury, extension injury that ruptured that tendon. They did wait a couple of weeks. I think they said it was 2 in the case study before they came in, and the physician actually had to do a full open procedure to try and retrieve that tendon. And then when they did reattach it, we can see the contracture that that patient still had because the tendon had shortened down so much. What they try to do, this bottom left image, we're looking at a zone 2 tendon injury in the finger. What they try to do is milk from the tendon out and massage it out so that they don't have to do as much of an open procedure. And the hope is if they can get that tendon out like we're seeing on the left-hand side here, they put in like a little kind of plastic sleeve or catheter. They feed the tendon into it and then pull that out in order to get to the relocation site. So they have to feed it back through all those annular rings also. So they're trying to avoid too much of an open invasive procedure. Sometimes that's not possible. Then they have to open the patient up more, or it's already exposed, like we're seeing on the left-hand side here. This particular patient, it was an injury that occurred with broken glass. It's zone 5 in the bottom left here, where they had severing of all the tendons as well as the vasculature and nerves in the area. And through surgery, 6 months later, look at the range of motion that the patient has on the right-hand side here. I'm thinking good therapy team also. Now, how the physician goes in, if you're able to read the op reports, or if you have your patients, and some physicians are allowing a little bit earlier active motion than others, it might come down to the actual technique they utilize to bring the ends of that tendon together. And what they utilize are different strands. You'll see documentation of what strand technique they use. Here's the best example I can give. Way back in the olden days in high school, we had to take home ec, and one of our assignments was we had to sew a skirt. And the way the teacher, checked to see if you passed or not is they took the waistband of the skirt and they pulled it apart as if you were going to put it on to see if all the stitches popped out. Not the best sewer. I just did one long running stitch all the way around. Teacher pulls my skirt. I can still picture what it looked like. Every stitch popped and did not pass that. I say use that analogy because when you think about the tendon and the tensile strength it needs to have and the gap resistance, you don't want the ends of that tendon to pull apart. The physician can't just do one running stitch around. It won't have that gap resistance. So they use different strand techniques. And if we look at the bottom image, what they do is they kind of loop it. So they'll loop one end of the tendon with the suture, go through, loop the other end, come back, and loop again. They'll do the same thing on the other side. And they end up creating, if you look at the top image here, I'll put a box around it. It's kind of like a little box technique. So then when they pull the ends of the sutures, it draws that tendon together. And then here, they'll do additional running stretch around it to secure it further. The amount of gap resistance is predicated upon how many different strands the physician is using, and you'll see that it creates this little box to give stability to it intrinsically. The research that I looked at, looking at when failure might occur of a reattachment or suturing technique of a tendon, is that if the individual has less strands that were utilized in order to hold that tendon together, for example, if they have 2 only, that they found failure tended to happen about 18 days out, versus if they had more like 6 strands that were utilized to secure it, failure tended to happen around 47 days out. So we need to remember that as we are rehabbing patients and we're controlling that mobility and active motion, we're concerned and mindful about disrupting that repair all the way through. That just because they were okay for the first couple weeks of active motion doesn't mean we're not still being cautious that disruption could occur if we put too much force across that repair. Secondary repair might be used in some patients where they have other conditions that need to be addressed, and then they may need additional grafting. This is an example of a patient who had sarcoma in the hands. They went in and they had to resect out on the left-hand image here. They needed to excise all of the tissues. Patient underwent radiation. The lumbricals were removed. They needed to revascularize the area. The fat, the skin was resected out. The tendons also. So what they did during that time while healing was occurring, remember that complex mechanism we talked about? They didn't want everything to scar down because then they can't get that tendon back through that annular ring in hopes of having function, even if they were able to use a graft. So what they put in here were like these silicone struts to keep those annular rings open while healing occurred. And then they were able to go back in, do some grafting, and look at the great range of motion that this patient was able to achieve. So just because the patient needs to have a prolonged procedure and a secondary repair with transfers of tendons from other regions doesn't mean that it can't be successful. This patient, I think this is over 6 months out that they had to wait before they had a bed that was healthy enough in order to even perform the tendon grafting for it to be successful. As we look at when this patient comes out of surgery with the different tendon repair procedures, we're going to see different types of splinting that are utilized. Historically, they utilize this type of Kleinert splint. This is an old style plaster one. They might be a little more slimline if you see them at all now. The idea is that it had little adhesive and rubber bands that are placed with hooks to the nail beds that held the patient down in finger flexion, and that's to relieve tension on that repair. And then the idea was that the patient could actively do their finger extension. Unfortunately, what the research found is that patients maybe weren't as diligent in doing the finger extension, so many of them actually led to finger flexion contractures, so it didn't quite accomplish the goal. What's utilized more commonly is more of a dorsal blocking splint to just keep them from moving into too much extension to avoid stressing that specific repair. When we look at rehab and when active motion can be performed, they consider the work of flexion. And this means that in addition to everything the physician considers during the surgical procedure, as healing is occurring and they're looking at starting to move and glide these different tendons, we want to make sure there are not any adhesions obstructing them. We don't want to have joint stiffness. The antagonist muscle also has to have appropriate length of it. But the big key they're finding is edema. That significant edema in the area surrounding the tendons places a lot of drag on them and resistance to gliding that leads to too much work and can lead to disruption of the repair. So early on, all the research is reporting to that really controlling edema is very important, that we educate our patients on that. They know how to position appropriately to additionally focus on minimizing that development of edema. The rehab protocol you're going to follow is from the physician. We're looking at initially limiting the motion to not stress that repair. Tendon gliding of the adjacent tendons is typically permitted. Early on, as I said, we're looking at immobilization as well as edema control. And this is going to last for several weeks. And then we're going to move on at the point that active motion can gently be started. Typically, place and hold exercises are utilized where the patient's joint is flexed down. They're told that they're holding maybe a butterfly, that they're not trying to crush. That's only the slight amount of tension, and then they can relax. And that may be repeated. And then we're going to see progressive moving towards resistance, up to 12 weeks out. The research that I looked at tried to see, what is the best post-op day to start some active motion or passive motion to avoid the development of the adhesions, but not have too much work of flexion. And what they found in the studies that I looked at is that somewhere between post-op day 3 to 5 seems to be most favorable because the swelling is diminishing and starting to subside. And then if you wait until day 7, by that point, there already seems to be adhesions that are starting to form, stiffness that's starting to set in. What we're seeing is earlier controlled mobilization as the preference for management of post-op patients with tendon repair. There are several different protocols that are out there. The Duran protocol utilizes passive finger flexion. The Kleinert, as I said, is looking at passive flexion of active extension. And the trend now is moving towards that early active motion for patients. A Belfast protocol might be how you hear it referred to. And I'll be honest, there are so many different little modifications and versions to it. Now, when you talk to the physician, if you want to understand why one patient can progress faster than another, you have some different aspects to look at. And the Belfast protocol that's commonly utilized is looking at maybe every 4 hours, having the patient perform just 2 repetitions of very slight passive range of motion or very slight active contraction, just very slow, early active to maintain the integrity of that tendon as it is healing. And they've demonstrated that on a cellular level, this appears to increase cellular responsiveness and to encourage that myofibril formation to promote good integrity of healing. When we're monitoring patients for a complication following tendon repairs, one that we are mindful of is the potential of Bose stringing. That is when the tendons may fall away from their bony alignment that may occur during different points in the healing process. We'll watch for tendon adhesions. It appears that somewhere between 3 and 6 months where tendon adhesions may occur that could significantly reduce range of motion for the patients. And about 20%, the data says, do develop adhesions that require surgical intervention to release them. Tendon ruptures, we discussed that we're trying to control edema, not progressing too quickly with range of motion, particularly that active contraction, and then we're not stretching. We don't want compositive movement where we're doing wrist extension and finger extension over stretching. And 2 specific things we're going to look at are quadrigia and lumbrical plus finger as we're looking at the tendon healing. And this image on the right, I like to show this. It is a great image looking at that annular ring, and I'll draw a circle around it here to show us the complex anatomy in this area. And when a patient's tendon ruptures, either if we're seeing them pre-op or post-op, and it was an unfortunate complication, this patient in the top image is being asked to flex their fingers down and that pinky is not going, and they did have an avulsion that needed a repair. Quadrigia, we are going to look at first. This is a specific complication that occurs in individuals who have had repairs of the flexor digitorum profundus. When we look at the musculature coming down into the hand, if I ask you to flex your fingers, you would be able to flex your index finger alone. But if I ask you to try and flex all the way down your ring finger or your middle finger by itself, the others tend to kick in. That's because on the left top here, that index finger does have its own portion of muscle belly, and then the muscle belly for the other 3 are more continuous. This is why quadrigia happens. When someone has a flexor tendon repair, if the tendon is tightened down too much, so if it is over-shortened, so for example, we're going to look here on the black represents the tendon portion of my ring finger, and the black and white is the tendon portion of my middle finger. So if I had a tendon repair of this ring finger, and the black is how short that tendon is now, when I go to flex down, it will flex, and then my ring finger, see how I still have all that white slack left in that tendon? I won't be able to flex that finger down all the way. I won't be able to generate good strength here. Even though it has muscle length and it should be able to develop tension, because they're all obligated to this same muscle belly represented by my hand, it's only going to go as far as that over-shortened surgically repaired finger. So when you see quadrigia, it's the finger adjacent to the one where surgery was that is unable to develop that tension of flexion. The reason this happens is if you think of a chariot with all of the reins coming out, if the rein was shortened on one of the horses, they're just going to be going in a circle. Even though the other reins are longer, they're obligated to go where the shortest guy is going. So this tends to happen in patients. If you notice it post-operatively, it would be something that you need to let the physician know, because it has to do with inappropriate tensioning of the flexor digitorum profundus that was healed. It may not affect quality of life. It may not require any revision. Does not mean the surgeon did anything wrong. It's just something that you would want to look for as you're assessing strength. You're going to look at the fingers individually also. Lumbrical plus finger is something that can also occur in individuals who have that flexor digitorum profundus tendon that has been repaired. What normally happens is when we go to flex our fingers down, we have our lumbricals, and our lumbricals perform this tabletop position of MCP flexion with IP extension. And there's a relationship that happens because of the anatomy in the area, that the tendon of the flexor digitorum profundus and the tendon of our lumbricals coming up, they become intimate with each other. So when the flexor digitorum profundus is flexing down, it triggers the lumbricals to relax so we can get full finger flexion. If someone has a rupture, so let's say you're rehabbing the patient and everything's going great, and then all of a sudden you start to notice that when you ask them to flex down, one of the fingers extends back out. So they're going to make a full fist, and one of them, the repaired finger, extends back out. The reason this happens is because as the flexor digitorum profundus is telling them to flex down, if that tendon has ruptured, the lumbrical now takes over, and that lumbrical performs the interphalangeal extension. So that lumbrical kicks in and does the interphalangeal extension, and that's why we see that finger kicking out. So it's another indicator that there has been some type of disruption to that repair that we would need to communicate back to the physician about. Other pathologies that we're going to look at related to the tendon are trigger finger or trigger thumb. This condition is not related to a specific trauma. It's more when we ask the patient to flex and extend their hand, they're likely to have a locking of that finger or thumb, usually it's the ring finger, where they are going to have a locking or a catching of it, and sometimes they need to manually extend it back out. The way that we grade this, whether it's in adult or pediatric cases, is a grade 1 is where they're going to have just pain and tenderness at that area of the A1 pulley here. Grade 2 is some catching. Grade 3 is where it may get stuck, but it can be passively extended back out. So it may get stuck, but I can pull it back out. And then a grade 3 is where they actually start to become contracted down. The reason this happens is related again to that flexor pulley system. When we look at the mechanism related to this, it is a stenosing tenosynovitis. Our tendon is covered by that A1 pulley. And when we look at the tendon in the right bottom image here, it should be nice and clean and smooth. And it's this outer avascular side here, smooth side of the tendon, that's gliding against the inside part of our ovoid cells, they're called, of that A1 pulley. So normally everything should be gliding normally. Unfortunately, what happens in this pathology is that that undersurface of the pulley becomes more like chondrocytes, they say. It becomes more fibrotic. And then that smooth tendon, the sheath of the tendon becomes hypertrophied and thicker, and it's the avascular side, so it doesn't heal as well. And we start getting a situation where when the individual flexes their finger down, all of that excess tendon sheath bunches up underneath the pulley and it gets stuck. It's similar to feeding an oversized thread through a narrow needle where some of the strands just don't go through. And that's what happens with this condition. It's a thickening under there. If conservative management is not successful, then there may need to be a release that is performed in order to open up that area, debulk it, in order to restore the gliding of the fingers. The physician can do an open procedure like we're seeing here, where there's an incision right at those pulleys, or there is a percutaneous technique where they are going to go in with like a little hook needle, similar to what we looked at with the ultra minimally invasive carpal tunnel procedure, and they'll slide that needle across to try and break those adhesions that are on the undersurface of that A1 pulley. They're trying to minimize damage to the tendon as they're performing this. It's described in the surgical journals as the physician should feel kind of like a little grating to try and break up some of those adhesions. When we're looking at rehabbing a patient from this, we want to avoid excessive pressure right over this region that we already know is prone to inappropriate healing. So we're not going to be using a lot of grippers or putty, sponges, balls, anything that puts that excessive pressure right over that A1 pulley that's trying to heal. And then we're also going to avoid that composite wrist extension and finger extension because it'll put excess stress across that pulley while it is healing. De Quervain's release is moving us over now to this radial side of the wrist. This is a stenosing tenosynovitis of our abductor and our extensor pollicis longus, repetitive type of motions using the thumb as well as ulnar deviation are going to cause pathology of those tendons. When we look at the anatomy in that area, we usually think of just the two tendons coming down into it. What they actually find surgically when they go in a lot and look at the area is there's this little septum in between the tendons. And then also in this bottom image, we're counting 1, 2, 3, 4 tendons. But I just said it's the abductor pollicis and the extensor pollicis, which is 2. They're finding that some patients, their abductor pollicis, instead of being one continuous tendon, it has what they call 3 slips. So it actually has 3 kind of little splits in it, creating more bulk in that area. And then that contributes to the degeneration that seems to occur in this pathology. So it might explain why some patients conservative management works and for others it doesn't. Some people just may be more prone to it. If conservative management is not successful, generally after 4 months or so, then the patient may be a candidate if the physician deems for endoscopic or open procedure to debulk that area. As we're rehabbing the patient, if they did have the surgical release, manual muscle test is usually deferred out to allow some time for healing of those tendons to occur for several weeks. And based on the incision approach that the physician uses, we're going to monitor the patient closely for any transient nerve damage that may occur. So we're going to look at that sensation to the incision as well as that surrounding area. When they come in with more of a longitudinal type of incision or an oblique incision as opposed to just a transverse, the research says that there's less of a chance of damaging the nerve, so they go in and do a blunt dissection. Where we're looking at sensory compromise as the nerve comes right in this area is potentially to the dorsum of the hand and the fingers. That dorsal branch of the radial may become compromised during surgery. So we just want to watch out for that. Dupuytren's contracture, coming back over to the palmar surface of our hand now. Dupuytren's contracture is actually a complication of Dupuytren's disease, which is a genetic condition where there is inappropriate formation of the palmar fascia in the hand here. And what the individual develops over time are these cords. On the right-hand side, we see this cord parallel to the line I'm drawing. That is not the patient's tendon. It is that fibrous cord that has developed in the palmar fascia, creating a finger flexion contracture. Surgery is generally indicated if the patient has a contracture of greater than 30 degrees of the proximal interphalangeal joint, because that significantly is going to limit the functioning of the hand. We also need to monitor patients with this pathology as those fingers may start to contract down. Is hygiene being able to be performed? Are the nails starting to dig in to the palm of the hand? In addition to, can they grip, can they hold things for the patients? If surgery is required, there are several different options that the physician has. And when you read the research about Dupuytren's, the success rate of surgery, depending on the study, is somewhere between 0 and 100%. And I'm not just being funny when I say that. It really, if you read it, and part of the challenge was there was no standard as to what does reoccurrence mean. This is a genetic condition that predisposes the patient to the formation of those cords. It's going to come back. It's just a matter of when. Surgery kind of just sets the clock back a little bit for the patient to buy them some time of greater function. And there was no standard way of saying, well, what is reoccurrence, to see if the surgical technique was actually beneficial. They came up with a board, got together, international group, United States, Canada, Europe, Australia, from all different countries, and they came together and said, okay, we need a definition of what is reoccurrence, and this is what they defined it as. They look at the patient post-operatively 6 weeks. So 6 weeks after surgery, whatever range of motion has been obtained, and then they compare the patient a year from then. If they lost more than 20 degrees from 6 weeks post-op to a year, that was defined as reoccurrence. Now we'll probably see better data coming out comparing these different surgical interventions that we'll talk about to see which one's most beneficial. Enzymatic fasciotomy is the least invasive and the one that has been emerging more recently. Xiaflex is what is utilized. It is a purified microbial collagenase that is extracted from bacteria. And when this is injected into that fascial cord, it disrupts the type 1 and type 3 collagen bonds in the cord, but it does not damage the type 4 collagen in the nerves, the arteries, and the veins, which is important. And it's a simple procedure where they'll inject the cord. Over a couple days, it'll lyse and start breaking down that abnormal tissue that has formed. This is very closely regulated by the FDA because it is extracted from bacteria. It was first approved in 2010 for one cord in the hand, and then in 2014 they said, okay, it's safe enough to inject 2 areas. So the physician injects at the apex of the cord, and then they're going to wait about 24, 72 hours. During that time, the bacteria, the collagenase is lysing and breaking down that cord. Patient comes back in, the physician mobilizes it to break up and restore the range of motion. Basic home exercise program, range of motion in all planes, and then usually the patient has pretty good recovery. What it actually looks like when a patient has this done, on the left-hand side, we see a injection site here. They do, on the right-hand side, you can see a little better. They will have a little bit of bruising into the area, and then we can see originally they had this contracture, and then they made some significant range of motion gains in the area. If you do happen to be seeing patients following this, they may be referred for therapy and not just at home with the home program from the physician. You're going to monitor them closely for any side effects of allergic reaction. They're likely to have tenderness and bruising in the area. You're going to look for any signs of excessive swelling, hives, difficulty breathing, chest pain, for more of that systemic type of response. Another option is the needle aponeurotomy. This is where the patient will have the cord in their finger and multiple small punctures are made. So the the physician goes in percutaneously with a little needle, and they're going to kind of divide out that contracted down cord where it's located. They describe that the physician really needs to tell the difference between what is the abnormal cord and what is the patient's intact tendon. The tendon is described as more rubbery, and oftentimes the patient is asked to contract so the physician can kind of go in and feel the tension of the different tissues to make sure that he is releasing the appropriate areas. Afterwards, active range of motion is usually started the first day to start getting that motion back. Nighttime splint to help encourage more of that extension posture as the patient is healing. And then limiting of grip for about a week is what's described. There seems to be a few complications that occur from this procedure, and they do not need to undergo anesthesia. So for elderly patients, it might be a good option for them. For other individuals where the contractures continue to reoccur, the problem is that instead of having this nice, normal, smooth tissue, initially they start to get like puckering, and in the proliferative phase, there are like wheels or circular formations that form of the collagen. And then we can see here, parallel to the lines I'm drawing, we start to see more lines forming as the fibers align along the normal movement. That's what creates the cord for the patient. And if it continues to reoccur, then the patient may require more of an open procedure where they'll come in the bottom left here, going along the normal lines for the patient. If they've been contracted down for a significant period of time, when they do extend that out, there's sometimes skin tearing, so a skin graft might be needed. This patient here in the circle I'm drawing on the bottom left has like a buddy graft where they took from an adjacent finger to graft over the site to encourage it to heal. So you might not just be addressing rehab from the release, but also from a skin graft. Postoperatively, the patient will have some type of bracing out into extension, holding them with a dorsal splint to allow extension and healing. They also want to try and decrease the mechanical stress that's occurring across those tissues in the palmar fascia. They don't want excessive compression or swelling on the neurovasculature in the area. When we look at starting range of motion, we're reiterating again that we need to be cautious when we're looking at how we're performing motion. That if we're working on interphalangeal flexion, we want to make sure that the metacarpal phalangeal joints are in an appropriate position. We don't want to have our patient fully extended. So if we're doing interphalangeal extension, we wouldn't want it in this position. We would want the MCPs extended, and now we can work on interphalangeal extension. Same thing when we look at wrist position. If we're working on that MCP extension, we want to keep the interphalangeal joints somewhat flexed so that tendons and the fascia are not being lengthened too much, and we want to look at our wrist position. We don't want wrist extension with it. That we would progress the patient to further along in our rehab. And the same for our home exercise programs. We want to be very specific with our patients to make sure they're not moving in positions that are going to stress those healing tissues. Outcomes comparing all of these different techniques, it's really hard to say which one is better than the other. The data that I have here comes from a review of 50 different clinical trials, over 4,600 patients. Most of the studies were large cohort, up to 92 or more patients. What they did find with the collagenase injection is that there were improved and beneficial short-term and medium outcomes. It hasn't been around that long. We don't have long-term outcomes. And interestingly, they did find the therapy was utilized for the majority of these patients. The needle fasciotomy, when they went in with that, they found that it has a greater reoccurrence rate, which makes sense because they're not resecting out the tissue, but it had less complications. On the flip side, the fasciectomy, lower recurrence because they're removing the diseased tissue, but greater complications. So it really becomes a physician decision along with the patient. It does let us know. We're obviously monitoring all of our patients for complex regional pain syndrome, skin tears, infection. We just may be a little more cognizant that that might happen with the open procedure patients. As we look at rehabilitation considerations for our patients following nerve, fascia, and tendon surgery, we're looking at managing that edema as well as joint protection during the recovery phase. We're going to follow that physician protocol. Splinting is likely to be utilized in those early 2 to 3 days along with a bulky dressing, and then weaned off to some other type of protective splinting based on the specific tissues that were involved. When we look at our exercise programs for these patients, the timing will be different. However, tendon gliding may be an important component of your exercise program. This is another example when you pull different research and different resources, tendon gliding is not explained exactly the same way every resource. I went right to the beginning. I went all the way back to the 1987 original tendon gliding document from the Occupational Therapy Association. So that's what I'm presenting here. Tendon gliding looks at having different positions that the fingers are moved through. It could be passive or active to ensure that that complex gliding between the flexor digitorum profundus and superficialis and all of the pulleys and the components, that gliding occurs at every area to avoid the development of adhesions and maintain the glide. The different positions include a straight position, and normally you're starting with a neutral wrist, so we're not stressing any repairs. The hook position is MCP extension and proximal and distal interphalangeal flexion. Full fist is everything flexed down. Tabletop position gives us MCP flexion and IP extension, and then straight fist from that tabletop just flexes our interphalangeal joints down with our distal joints still in extension. This is going to be utilized usually several repetitions, several times a day for the patient, and we'll start with that neutral wrist and then progress them to flexion and or extension at the appropriate point as enough healing has occurred based on the tissues. postoperative complications for all of our hand patients that we're also monitoring for is the potential development of a thrombosis. We note that circulation, we're going to be checking down into the distal ends of the fingers. Even if the surgical procedure was more proximally, we'll rule out thoracic outlet syndrome, Raynaud's disease from the cold, if there's external compression that's causing the circulation changes. This occurs oftentimes during surgery as they're working on the different tissues. There may be an axial pull that's placed along that vessel, and it damages the endothelial lining that allows it to a little more readily form that thrombosis. This is an example of a 25-year-old 10 days after correction of a boutonniere deformity for arthritis. We can look at the finger here and see that there is significant compromise to the circulation. On the scan on the left, there was no distal perfusion to the tip of that finger. They immediately started the patient on IV thrombolytics. They did restore color circulation to the area, was improved. Unfortunately, what happened over time on the far right image here, about 2 months later, there was dry necrosis that occurred and spontaneous amputation of that distal end of the finger. We do want to avoid that for our patients. Looking at bony structures now, wrist and hand joint reconstruction. It's not as common for osteoarthritis to have many surgical interventions in the hand as we do for the hip and the knee. Most of the time when there is surgical intervention in the hand for osteoarthritis, the focus is trying to relieve the pain that the patient's experiencing. It may not necessarily restore too much function for them. The most common joint where we'll see surgical intervention is the carpometacarpal joint, or the basal joint of the thumb. We have our trapezium that is articulating with our first metacarpal here. And as we do our different functional activities, if there is arthritis in that area causing degeneration, we're going to start to see a shift as that joint deteriorates. That's going to kind of shift all of the joints more proximally because there's such an abduction force placed across that thumb region. What happens over time is if the base is shifted, then everything kind of topples going further up. So surgical intervention may be necessary to restore some functional use of the hand. One procedure that might be utilized is a trapeziectomy, where on the right-hand side here, they're going to take out that trapezium. And then some surgeons may also perform a ligament reconstruction. What they look at is, okay, so if the patient needs to functionally utilize their hands and they don't have that trapezium there, we need to restore some type of cushioning or mechanical alignment to that hand that can sustain the forces of different functional activities. And what they will do is come in and they're going to take the flexor carpi radialis and they will remove it from its insertion. They cut off a little piece of it on the right here and they wind it up like a little anchovy, and they're going to place that into that location where the trapezium used to be located. The remaining flexor carpi radialis, they're going to reattach to the first metacarpal so it still can function for wrist function, but that extra little length, because they shifted the insertion, they can put to give some cushioning to that thumb joint in order to restore function. The patient generally for about a month is going to be in a thumb spica cast, and interphalangeal joint motion of the thumb may be permitted. The physician protocol is likely to, around 2 months, start weaning them off with the start of some isometric strengthening, and then progressing the patients more at 3 to 6 months out of their return to typical strengthening and functioning. For the patients, again, we're looking at controlling edema, gentle activity of the hand, educating them on, how to brush their teeth, not to use that electric toothbrush initially, and modifying with adaptive equipment as necessary. As we look at fractures that can occur, fracture of the distal radius is one that occurs from low energy trauma in our older individuals, a fall from standing height or less, or high energy trauma in our younger population. When we look at this distal end of the radius, it has many different architectural components that allow it to function, that allow this articulation with the lunate and the scaphoid for wrist motion to occur. And when the physician goes in to perform surgery to realign a fracture that has occurred, they have to get the length right of the orientation between this radius and ulna, because if the radius becomes shortened too much where the ulna protrudes down further, this creates excessive compressive force on those ulnar carpals and can shift the mechanics for functioning of those and trauma to the structure, soft tissue in that area. One option is a volar locking plate. Now, the dorsal locking plate is what's utilized most commonly. The research is saying that the volar locking plate on the palmar surface is an option for certain patients, that it does seem to allow for earlier mobility of the patient. The downside is you want to know where the plate is. You just don't want to know the patient has an ORIF, because if the plate is on the volar surface, like in the image that we're looking at here, that is very close to all of these tendons in the area. And there's a greater potential of nerve compression of that median nerve, potential irritation of those tendons. So eventually that plate does need to come out. So monitor your patient closely if they do have that volar plate for those particular compromise. Intramedullary nail might be utilized to stabilize the fracture. This is where they might even go percutaneously in order to stabilize the fracture site, earlier mobility. We do need to watch the patient to see if there was any nerve involvement as they place the pin into the area. Internal fixation is going to be utilized when they need more stability applied to the area. We'll have the screws going through the skin. The challenge is that pin care. And pin care is so important because there's a direct pathway into the bone that can lead to the development of osteomyelitis. I looked for some standard protocol, and though all the research recognizes that infection at the pin site is a big concern, there's no one set protocol. And when we look at this, we should see a normal kind of serosanguinous drainage possibly at the beginning, but nice clean area. If we look further at the progression, we might see some erythema around the pin site. That progresses to more drainage and then purulent drainage where we potentially see the risk of infection for that patient. So we need to make sure that pin care is a part of our patient education for the patient and that we monitor that closely. Tight cast syndrome, if a patient has a closed reduction, we're going to look at that it is not too tight, restricting circulation to the area. It's how they determine how tight to make the cast is they look at the anticipated amount of swelling at the site of injury and they compare that to the other side, and it's a mathematical calculation to come up with a cast index value, and 8 seems to be the target. If the cast index value is too big, then it's going to allow for movement and loss of fixation, stabilization. If it's too small, then it can be tight cast syndrome. Looking at some of the smaller bones of the hand, our scaphoid, that is part of our articulation to our radius. It is a commonly fractured bone in the hand, and when we look at the structure of it, it can have a waist fracture through the middle, a distal, or a proximal fracture. If you're looking at the radiology reports, there are several different classifications that are utilized to explain the fracture. And one of the biggest concerns is avascular necrosis. There's a peculiar blood supply that comes in where it comes from proximal, goes distal, and then takes a U-turn, and same thing on the other side. So ultimately that leaves this proximal pole without a good vascular supply, placing at a greater risk of avascular necrosis. When they go in to stabilize the fracture, they take this into consideration and they need to get good alignments, not only for future functioning of the hand, but to try and really encourage healing. And they have all different types of screws that are utilized. I think it would be really neat to just know I have a purple screw in there if I had a choice. But what they do is they're made now so that as they wind them in, it kind of pulls the bone ends together. And they're starting to take grafting. Sometimes it's from the iliac crest, but that's not have a vascular supply attached to it. What they'll do is they'll take a little notch here in this bottom image out of the radius, and they'll slide it over along with its vascular supply and put it kind of as a little patch over the graft site in order to promote further healing. The fracture healing of these distal radius, of these scaphoid fractures is prolonged. It does take a lot longer because of that precarious blood supply. So we're going to see that remodeling phase is looking several months out for the patient. Because of that, when we go through our rehab protocol, we're going to see a slower progression for the patient through rehab. They're going to have about 2 to 6 weeks of splinting where we're just doing elbow and finger range of motion. Maybe they can lift about a pound. Looking 2 months out plus is when we can start doing our wrist and thumb only active assisted range of motion, and then over 10 weeks. And we want to be cautious with these patients that they're not engaging in any activities where there's vibration going through that hand that could disrupt healing, where they're placing themselves at any risk of fall or balance loss, where they might even catch themselves, even if they're splinted or casted, that could put force through that fracture and disrupt the healing of it. Other carpal that we're going to look at is the lunate. The lunate is part of that articulation with the radius for our wrist joint, and it also plays a really critical role in the alignment and the stability of all the carpals in general. It is the only carpal bone that does not have a muscle attaching to it, so it relies on its positioning. One of the challenges with the lunate is that it is wider on the palmar surface than the dorsal, so it's prone to kind of slipping out without much force located in there, and then it could slip right into that carpal tunnel with a fouche injury. When we look at different injuries that occur, it can just be a tearing of the ligaments that stabilize that lunate, and the Mayfield classification is what's utilized. To know that one of the ligaments has been disrupted, you're going to see that shift of the lunate away from the scaphoid. And that's what we're seeing in the bottom image here. You see how you kind of see this space between those bones? That would be a stage 1. It's called the Terry Thomas sign, who, I'll be honest, I didn't know who that was. I had to look him up. Here's how I will modernize this sign. If you picture a young Zac Efron, Madonna, David Letterman, Georgia Jagger, Michael Strahan, trying to hit on every decade, they have that space between their teeth. And when you look at the slip, that lets you know that's kind of that space between the lunate and the scaphoid, that there is disruption of that ligament. The staging increases to 4 to the point where the lunate is actually dislocated out into that carpal tunnel. This is considered a devastating injury of the hand. That perilunate, so the bones around the lunate, need to be stabilized in order for hand function to occur. And many of the surgical references say that only life-threatening injuries should supersede the need to address this, that at least the person should be splinted to try and stabilize it, because years out, even if they try to address it, patients still have compromise. If the lunate is fractured, they will try to stabilize that and repair it. If the instability is too significant, the patient may need a carpectomy, removing all of the bones, and an arthrodesis. This is the image of a 32-year-old who sustained a motor vehicle accident. It was 4 weeks. He had just discomfort and pain that wasn't specifically diagnosed. It was being treated like a wrist sprain in the case study. And it turned out that it was this perilunate where the ligaments had shifted, the stability of all the carpals was off, and they ended up having to go in and do a carpectomy for the patient. 1 year post-op, the grip strength was about 85% that of the opposite side. So this was a Mayfield classification 4. Post-operatively, for patients with this surgery, they are going to be splinted, and then they're going to be weaned to a shorter cast and splint. It's important that we monitor these patients for that median nerve damage if it slipped out into the carpal tunnel, if the fracture's not healing, and if they develop any avascular necrosis, which is called Kleinbach's disease. Another concern is when the lunate and the adjacent structures are unstable, that there is shifting that occurs over time. And we have to be cautious when we're able to start weight-bearing activities. That's pushing up from a chair, pushing a drawer closed or a door. That when there's instability in that area, as there's active movement of the hands, the lunate and the scaphoid kind of twist and rotate on each other. That can put excessive force in that area over time with the patient if they haven't developed good stability through surgical repair, that they lose the wrist alignment of the scaphoid, the lunate, the radius, and the other carpals. And every time they use that hand, there's excessive stress going into those joints that have a lot of cartilage surrounding them, and it predisposes the individual to the development of osteoarthritis. Consideration might be, if long-term our patients are at risk for that when they have scapholunate ligament injury, that teaching them that joint protection to be lifelong might be a consideration early on to help avoid something down the road. Kleinbach's disease is osteonecrosis of the lunate specifically. Following a trauma, like we just discussed, where the individual may have sustained a fracture of the lunate that is not healing, if that blood supply is disrupted, it would be a stage 1 if it's noted immediately following trauma for the individual. Stage 2, a progression as that vascular supply is compromised going to that bone. Sclerosis of the lunate can happen where it starts to deteriorate and break down from that lack of blood supply. We might start seeing the changes on the CT scan at that point. As it continues to progress, if you look at the scan up here where the lunate should be, we see that it's just a dark space. That lunate actually collapses down as it continues to have less blood supply to it. And then once it collapses down, all of the carpals that are surrounding it become shifted. And now that changes the mechanics of the hand and alters the articulations, the function, and then the progression to stage 4 would be those arthritic changes that we discussed setting in. So surgical intervention may be necessary in order to halt this progression. Revascularization surgery might be an option if it's caught early enough on before the lunate has completely deteriorated. They'll do something similar like they do from the scaphoid, take that little piece of bone with its vascular supply from the radius and swing it over the graft site in order to try and give it a blood supply and allow a better chance of healing. If that's unsuccessful, they might need to do an osteotomy in the area of the ulna. The problem is that when the carpals shift and that lunate shifts, then we end up in that situation where that mechanics are altered and the articulation at the wrist between that ulnar side might be creating too much compression. And if there's too much compression here on that ulnar side, they may need to take a little wedge of bone out to try and restore normal mechanics for functioning. In some cases, they have to take out all of those carpal bones and do a fusion or an arthrodesis for the patient in order to allow some function to be regained. This is why it's important that we're monitoring our patients for that persistent pain, sudden loss of range of motion if they were progressing well, any signs that there may be that avascular necrosis during healing of the carpal bones, so we catch it sooner for intervention. Different casts and splints are going to be utilized as we're rehabbing our patients. We mentioned for many of the different surgical techniques that stability is going to be from an external source. Even if they had some type of internal fixation, they might additionally have some splinting that is utilized. Several different types are applied postoperatively for the patients. It's important that if it is a type of device that can be removed for when they're performing their exercises or for hygiene, that we educate them on appropriately how to reapply the device. I've oftentimes seen patients, they come in and yes, they have the splint, but it's just not on right, that it's not executing its function of providing stability to that joint, or it's not truly restricting the motion of that tendon. The first one that we're going to look at is the thumb spica splint. This has several different lengths to it, but the idea is when this is applied, the individual has the thumb out in some degree of abduction and extension. You might hear it referred to as the wine glass position. So as the patient's holding a wine glass, that's about the position that the thumb should be in to allow alignment of the joint. They may also have the patient hold like an ACE wrap package in the hand to get that thumb out in the position, and then the stability will come down past the wrist. It may just become slightly proximal to the wrist, or it could go down further, as in the example that we're looking at here. Mindful that the goal is to be stabilizing that lunate and scaphoid here if there's a fracture, to be taking the slack onto those tendons of the abductor and the extensor pollicis longus if there's been a repair or a decompression in that area. So when we look at the patient on the left here, first thing that should jump at you is when we look at the gapping between the thumb and the splint on the far left. This splint is not accomplishing anything that we just discussed. So even though they reapplied it, it has good padding, it's not stabilizing the way it should. And also you can see it's very short here. It's ending much more proximally, almost on the thenar eminence. So it's not even stabilizing the joints for this patient. Volar splinting is going to be on the palmar side. This splint is going to have the hard part of the splint, putting the patient in a position of metacarpal phalangeal flexion with IP extension, and then it's ace wrapped around to provide some stability for the patient. You might be thinking of this in other versions of our cock-up splint position, where it's putting the wrist out in some extension. It may not go all the way down to the fingers. This might be utilized for an individual who has a carpal fracture to provide stability, carpal tunnel splinting at night, or if it is utilized during that return to activity period for the patient. You will not see this utilized for that patient who has that distal radius or ulnar fracture, because they can still do some pronation supination, so that could disrupt the alignment of the healing. Ulnar and radial gutter splints. These are going to run either along the ulnar or the radial side. It will come along the forearm, go up past the metacarpals to the phalanges, kind of like a trough on either side. The idea is that it's going to stabilize the entire region, and we might see this utilized for patients who have metacarpal or phalangeal fractures. It could be a little bit shorter if it's just a phalangeal fracture. When we look at our patient on the bottom left here, again, we see a lot of gauze in the area. It's a very, very short splint. But see how the ace wrap goes up so high? Kind of makes me think that it was intended to be a little bit longer. And then again, how much is it really stabilizing if there is a more distal fracture? Patient education is important to make sure that our splinting is accomplishing its goal. The sugar tong splint is going to stabilize our patient. It's going to come around the entire distal arm. It will wrap from the palmar surface up around an elbow. That's in 90 degrees of flexion, and come around the dorsum to stabilize. Because this splint is going to stabilize across the elbow as well as across the hand, and this could be casting also. This is a U shape. And the reason they call it sugar tong is if you think of tongs that you use for like barbecuing, or they used to pick up those little sugar cubes, it creates that trough that goes around. The idea is it's going to stabilize the wrist, the elbow, and really control rotation also. We might see this utilized more for that distal radius fracture, for the lunate fracture where everything needs to be stabilized, because remember, it articulates with the carpals distally, but also that radius proximally. And I have to say that hats off to all the OTs and other clinicians that are out there making splints. I remember in school, a practical where we had to make just basic resting hand splints. You know, the alignment is pretty straightforward. And I went to smooth that one extra edge. I had to go for that A. So I'm using the heater, the blower, and heating it up that little bit. And you guys can picture what happened. The whole thing just melted. So we know that when our patients are wearing splints, we have a lot of considerations in terms of pressure areas and educating them, watching for skin breakdown, particularly if the diagnosis they have contributes to sensory impairment. We need to make sure that we're educating them appropriately, and that we do have an appropriately fitting splint and cast. our patients are recovering from their different surgical procedures, in addition to this, we need to think about how are they going to perform their different functional activities. They might be in need of some different adaptive equipment, either because they're changing hand dominance while they're healing, or when they can start utilizing their operative hand again, we need to make sure the forces are appropriate and that it's easy for the patient to perform the activity. We have two kind of groups of considerations. One is the external pressure that is going to be placed across the hand, particularly if they have an incision site or a pathology of the fascia or that A1 pulley where we want to avoid the excessive pressure. Think about when they're trying to open a bottle, if it's too tight. If surfaces are slippery, that's going to be more difficult for them to have to exert more force across that can compromise the tissues in the area. Just holding cold objects, we might need to educate our patients when you go to reach in that fridge or grab that ice, even if you can start to use your operative hand, maybe you should be using the other hand because we know cold is a vasoconstrictor. In terms of internal pressure, we're going to consider the tension of grip, the amount they're holding, their forces on their hand. When they can start using the hand, or even if they're in a cast or splint, if they're still grabbing and holding things, even now, how much force are you holding your electronic device with, or the remote, whatever you're holding right now? How hard are you squeezing it? Are we always really cognizant of that? We may be creating more internal pressure of muscle contraction than is really necessary. We might be sustaining a position for too long of a tendon that's healing, and educate the patient on all of these aspects. When we look at the specific types of adaptive equipment that we can have our patients utilize, we're going to consider the lever arm. We know a longer lever arm can make things easier, that they have to use less of a muscle contraction. Maybe going old school with that pant hanger, instead of those tiny little metal clips, maybe they get more of this hook type where they can use the palm of their hand and their shoulder, even if it's the non-dominant hand. We want to look at using less fine motor maybe as healing is occurring or earlier on, that instead of having things in tubes that have to be squeezed, can it be in a pump that can be utilized with more proximal pressure? Changing the grips. You can easily purchase, they kind of remind you of a pool noodle, except they're thinner and smaller with a little slit that you can put around the handle of anything to enlarge that grip. That changes the force of the muscle contraction needed, redistributes the pressure. Even if someone's out to eat or at home, instead of using a regular dinner knife, maybe they use a steak knife because number one, it's a larger grip. It has more serrated. It usually has a little curve to it, so it's more of a rocker. Lots of adaptations we can make. Even something as simple as telling someone to wear rubber gloves to give them better grip control might be helpful in allowing healing to occur and redistributing pressure and forces. And as we talk about healing, we of course need to address smoking. We know that smoking has many negative consequences. As we specifically look at healing in the hand, the concern with smoking is that it is going to inhibit those osteoblasts. They have found in the research that there is altered dividing of the cells. It doesn't allow healing to occur as well, and that new bone formation. There's alteration from many components of the cigarettes, specifically looking at the nicotine that's found in the cigarette. This is going to serve as a vasoconstrictor. They find that the platelets actually aggregate more. So in addition to being a vasoconstrictor, it changes blood viscosity, which can alter the circulation to the area that is attempting to heal. The carbon monoxide from the cigarettes changes oxygen transport and metabolism. So does the cyanide. It seems to inhibit the enzymes that are supposed to instruct the oxygen to be released for transport. They actually did a study where they had individuals use an e-cigarette because people may think, well, that's a good alternative. So they had them use the e-cigarette with nicotine and then without nicotine. And they used sensors, ultrasound sensors, deep and superficial, to look at the oxygen in the area of the hand. They monitored them for while they were smoking for the 5 minutes and then 20 minutes after. It was amazing that they found that there was a decrease in the hand microvascular circulation up to 20 minutes after they stopped using the e-cigarette with the nicotine in it. There was a 77% decrease in the superficial blood flow and a 29% decrease in the deep blood flow. So significant compromise to the healing if that patient had a hand surgery. What they do find in other research is that if someone stops smoking, that about 4 to 6 weeks prior to surgery, that there is a significant decrease in complication rate by about 40%. So that's a positive we can look at. In conclusion, we have covered many different surgical procedures of the hand to take a look at and understand the anatomy in the area and how we should monitor our patients post-operatively, as well as considerations we should have while we are going through their rehab.
Are there any other ways to alleviate ganglion cysts? The physician's going to decide between the different management options, either surgical or non-surgical, for each patient. Generally speaking, for patients who are experiencing pain, non-surgical management is first attempted. The physician may do an injection of an anti-inflammatory corticosteroid and then splint the patient to try to have them rest the area and see if that alleviates the discomfort that they're experiencing. If that does not work, then another option might be to do aspiration, where they're going to go in with local anesthetic first, and then they will try to drain out that fluid from the cyst. The challenge is that in many of the cases, it does reoccur because the cyst's connection to that tendon or joint capsule where the synovial fluid is coming out from still exists. So if that root is not removed, then there's a risk of reoccurrence. Some reports say that with aspiration, there's about a 40% cure rate for individuals. If repeated aspirations are done up to 3, it seems to have more like an 85% cure rate. It's going to vary, though. They have noted that volar cysts may not be safe to do with aspiration because of their proximity to the vascular supply in that area. So the physician may then opt for surgery. You may have heard in some instances that people or the physician will just compress the cyst to try and rupture it. From what I read, the instances where that's indicated are more when it's a newly formed cyst, so that membrane is thinner and there's less fluid in it. So once it's compressed, it's just reabsorbed. If those conservative managements are not successful, then the physician is going to look more at the surgical options if the pain persists, and if there's any then compromise to neurovasculature in the area or to function. At that point, then there are a couple of different options to either go in arthroscopically or with the open procedure to remove that cyst, as well as its connection to that tendon sheath or synovium. How does the physician make the decision to do a nerve transfer versus tendon transfer? I tried to find some information as I was researching for the course, also answering this specific question. And what comes into play is the injury the patient sustained, what muscles are involved, is there scar tissue? They're going to consider donor sites and recipient sites. There are many different considerations. I did read one systematic review from 2017, and they concluded that there's no one clearly superior technique to looking at nerve transfer versus tendon transfer. But there are some advantages of one versus the other. They said that, tendon transfers historically, those are the standard surgical technique that are used to replace loss of function associated with this particular study was looking at radial nerve injuries. However, there is that concern that when you move a muscle from a donor site, that donor site is going to lose some of its strength. So that's why consideration is given to redundancies in synergists. And well, what is the more functional, more critical motion? Can they sacrifice that donor site? One advantage that was highlighted is that there is a quicker return to active motion when a tendon transfer is performed because the donated muscle is intact, it has its innervation. So once healing occurs of that transfer, then activity can follow. Nerve transfer, on the other hand, they're finding that it may offer patients some more meaningful gains, and it doesn't have as much of a risk as compromising that donor site. What they theorize is that if you're just moving the nerve to the muscle, and this is assuming that the tendon is intact, that the muscle is intact, and it's an option for the physician just to move that nerve over. This study, again, was looking particularly at radial nerve involvement. They theorized that when there is that nerve transfer, the donor site is going to have axonal regeneration because it's healthy to start with. So it's going to regain some of its strength back versus a tendon transfer where you've taken away from that donor site. And maybe it can build up some strength of the synergists, but the donation is already gone and used at the other site. Also, they're noting that when a tendon transfer is done, that there's a lot more dissecting that has to occur to relocate that tendon versus when they're just doing a nerve transfer, that there's less trauma sustained in the tissues in the entire area at both the donor and the recipient sites, less risk of developing scar tissue that could create adhesions and lead to decreased function. They're also noting that when they do the nerve transfer on the more disadvantaged side, that there is then that time needed at that recipient site for regeneration to occur. So the time to return to more of a clinically relevant and clinically recognizable functional recovery is longer for the patient. It could be as far as a year out recovery time. But again, it's a newer technique, so there's still not enough research to say that one is over the other, but those are some of the considerations that the physician is going to take into account when deciding between tendon transfer versus nerve transfer. When we look at the intrinsic muscles of the hands, we're talking about the lumbricals and the interossei. When you're going to use these different exercises that we're going to discuss are going to depend on the procedure the patient had, where you're at in progressing them through the post-surgical protocol. So you'll implement what we're discussing appropriately based on your patient's healing. For the lumbricals, they perform MCP flexion with IP extension. So that's our tabletop position of our 4 digits is performed by our lumbricals. To exercise this, one way that you can do this is to have the patient start in MCP extension. They may be doing this with the wrist supported in a neutral position, elbow on the table, forearm in neutral, thumb away from the palm of the hand. And you can have them start in MCP extension and IP flexion. So this will be the start position. The hook will be the start. And then the cue is important. You're going to tell the patient that what they're trying to do is push their fingers away. So they're trying to push their fingers out. So starting them in the hook, if you just tell them to push their fingers out, they're going to go right out into that tabletop position. So we're going to start in a hook position. We're going to ask them to push out, and that would be the exercise to focus on our lumbricals, this position. If we want to add a little bit of resistance to that, we can add some resistance to that middle phalanx as they're pushing out. We can give them some resistance against there. That could either be them performing it or the clinician providing it. So you're going to, as they're pushing out, give them some resistance on that middle phalanx. You can increase the resistance that you're providing by moving more distal, change that lever arm to the distal phalanx and have them push out. And even a patient could be performing this as part of their home program. Maybe they're using the palm of the opposite hand to push out against, to give them that resistance. Or you have them, using the theraputty to push out to perform it. Different ways that you can achieve that. Our interossei muscles are our pad and dab, if you remember back to school, committing that to memorization. Our palmar interossei are going to do adduction. So that's our pad, and our dorsal interossei are going to do abduction, moving away from that midline of the middle finger. When we look at how to perform this, you might have the patient supporting their hand on the table, on the surface. Not only does that provide stability to the wrist and the other joints so that you can focus and keeps them in the same plane of movement to minimize substitutions, and then we're gravity eliminated if we're resting on our tabletop surface. You can eliminate friction if you needed to, depending on how weak they are. What you're going to do is, ask them to spread their fingers out. I'll do it this way just so you can see better what I'm doing. Spread the fingers out and then pull them back in. So working those interossei, you can apply resistance to that proximal phalanx as they're pushing out, whichever digit you're focusing on. Apply resistance for them. You can make it isometric by applying resistance there, or concentric contraction.